Hello and welcome to the Completed Life Initiative's latest symposium, Last Hellos, New Models in Global End-of-Life Care. This symposium asks the question, how do we navigate one of life's most transformative experiences, our dying?
Drawing inspiration from Australian poet Les Murray's observation that these kind of questions summon last hellos. Today's Global Symposium welcomes speakers from Australia to Belgium, the United States to Rwanda, as we explore new models in end-of-life and palliative care.
From the origin of what it means to be palliative in the context of Aboriginal communities, to the scientific inquiry into the effect of placebos, from research into personal narratives of end-of-life visions, to expanding eligibility considerations for medical aid in dying. This two-day symposium invites you to contemplate one of life's most powerful transformative experiences.
Your presence in this virtual space means a lot to us, and we are grateful for you tuning in today. Be sure to stay till the end of this presentation, as there will be an opportunity for you to join a Completed Life Initiative team member and your fellow symposium attendees at our virtual event cafe. Thanks for joining.
Hello and welcome to the symposium session, What's Now versus What's Next? The Future of Medical Aid in Dying in the United States. I'm here with distinguished guest, Professor Thaddeus Pope. Welcome, Thaddeus.
Thanks for having me again.
Of course. As a prelude to diving into public policy and legislation surrounding the future of medical aid in dying, recently I came across a poem by Pulitzer Prize winner Tracy K. Smith called My God, It's Full of Stars. In the poem she wrote about her father, she has a wonderful line where she says, "Maybe the dead know, their eyes widening at last, seeing the high beams of a million galaxies flick on at twilight, hearing the engines flare, the horns not letting up, the frenzy of being. I want to be one notch below bedlam, like a radio without a dial, wide open so everything floods in at once, and sealed tight so nothing escapes." Two phrases, one, the frenzy of being, and two, like a radio without a dial, are poignant. It reminds me of transitory moments that perhaps are the building blocks for our final moment. And it reminds us of our mortality. What does it evoke for you?
So I love the fact that you guys integrate poetry into a lot of the programming at Completed Life Initiative because it's so powerful, right? I mean, the sorts of questions that you're addressing are so consequential and meaningful. So I love that, and I love the fact that that you just read that because I guess I'm so much of a scholar, right? I'm always focused on what does the data say, what did that court say, what does the bill say, and it's the human stories I think that are the centerpiece of all of these end of life discussions. Yeah, I don't know that I could translate that back into. I guess that's sort of the point of poetry is you can't quite put it back into regular words. I think thanks for starting with that.
Oh, sure. If I may be so bold to ask, is there a moment where you might have been able to reflect on mortality in your youth, or perhaps a first experience of someone close to you dying? Perhaps a moment that is sparked by what Tracy Smith mentions as the frenzy of being, but perhaps stepping back and thinking about it like a radio without a dial.
Yeah. So when I was between like 0 and 20, I mean, obviously some great aunts and other people in the family died, but I guess none of them were like super close relatives. What really, I guess, hit me sort of in a real way, like a bus, was when I went to grad school. So I went to Georgetown, but both for my law degree and for my PhD in philosophy. And I remember watching a film, the Dax Cowart film, which used to be a key teaching tool. But it's literally a patient who has been terribly, terribly burned, and saying, and they're treating him, but he doesn't want to be treated. He doesn't want to live in that severely burned way. I mean, he's now blind. He's lost a lot of mobility, lots of other things. And so the whole film is just basically people treating him and him saying, please stop it, stop treating me, let me die. And so in fact, that film was so consequential. I wrote my whole dissertation for my PhD on paternalism, right? Which is, when can somebody treat you, or the doctors thought they knew better for what was best for Dax than Dax thought for himself. And I thought, that's so offensive and insulting. That they think you don't know what is in your own best interest. You don't know what your own preferences and goals are. You don't know what matters. We know better than you. And I thought that doesn't seem right. And so that it's sort of that end of life case. It's not mine. It's not for my personal life, but it's from, I guess, U.S. history. Really pushed me down the whole path of thinking about individual liberty, and especially the scope of individual liberty at the end of life.
Wow, I thank you so much for sharing about Dax and his story's impact on you. I remember studying the story of Dax in graduate school and just being blown away at how they tortured him and how he begged, to be kind of released from his body. But he ended up living, which was a big surprise to me. But
and he went on. He went to law school. He became a lawyer, right? And so you would think, oh, maybe looking back, he thinks, oh, maybe I made an impulsive decision. No, right? Every single interview, 10 years later, 20 years later, he'd still say, no, they were still wrong, right? I'm not giving them any retroactive consent. I'm not regretting, or I'm not, I think I made the right decision, and I wish they had honored my decision. They were wrong then, and I think they were still wrong. So despite the fact that, yes, he did go on and in fact had some measure of success, and he got a very large, monetary settlement from the oil company that caused the explosion in the first place, none of that, quote unquote, made it any better, right? And so I always thought that was very powerful as well.
So really kind of a powerful way to step into not only individual liberty, but end of life rights and that space of kind of a fierceness of fighting for the individual's desire rather than external social societal desires.
Yeah, and maybe, yeah, absolutely. And maybe the reason we both remember this is because it was on video, right? There were other famous end of life, like Elizabeth Bouvier, lots of other famous cases from around the country, but they weren't on film. And I think the fact that you literally could see him screaming is super powerful. And I mean, and I know you guys have a film series and show films like the Zitter films and other films. I love the fact I just started watching the Netflix series Take Me Out Feet First. I mean, so there are things you can do through film and through poetry that you can't do even if you get all these law professors and bioethics professors. Like, we can't convey it as well as these first person narratives are able to convey the weight of the stories, or poetry is able to convey the weight of these stories.
Beautifully said. Thank you. And I'm struck by how both film and media and public policy and bioethics and law, they need each other, and it's cross-referential, and it's an interesting integration that film portrays individual suffering in such a a vivid way that as humans, I think we have a visceral response of, oh my gosh, I can't imagine what Dax went through.
Yeah. 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 I mean, that's, yeah. It's interesting that when you talk about, about MAID, medical aid in dying, that having been to like whatever 100 hours of state legislative hearings, most of the hearings is not experts coming to talk about data and stuff. Most of the hearings are terminally ill patients talking about their condition, right? Or family members of terminally ill patients, because it's that first person. I mean, because that's what I think the assemblymen and the senators, they need to hear it and they need to see it, because that's what we're talking about. So I could come in with charts and PowerPoint slides and stuff, but it's so even in the hearings, it's overwhelmingly, both by time and by number of witnesses, it's overwhelmingly patients and families of patients, as it should be.
As it should be, absolutely. So kind of taking it as a step into and a step back from the typical discourse around medical aid in dying from a legal perspective, if someone were to walk off a deserted island where they haven't been in contact with the U.S. news for a long time, how would you kind of orient them to understanding what medical aid in dying is and why it's important?
So obviously we all die. 3.5 million people die every year, and many of them want to control the timing and the manner of their death, and they already do that. So I guess the first thing to note is the context, which is even in New York, even in Alabama, right? People who have end-stage renal disease are stopping dialysis, right? Even if they're not getting a kidney transplant, they're going to die if they stop dialysis, but they do it. People turn off lots of other stuff, right? They refuse feeding tubes, they refuse antibiotics, they refuse mechanical ventilation, and they've been doing that for decades and decades, right? So people already control the timing and the manner of their death through their healthcare decisions. So this is just one more option, because there are people who are dying who, I guess the way to say it is they just don't happen to be dependent upon any form of technology or life-sustaining treatment. If they were, they would absolutely have the legal right to just turn that off, whatever that, or stop it, whatever it was. But they don't have anything to stop or anything to turn off. Nevertheless, they either have current suffering, physical or existential suffering, or it's imminent, right? They're afraid of imminent existential or physical suffering that's coming up, or might come up in the immediate future. And so medical aid in dying is basically their right to ask a clinician and receive a prescription drug for that they would then self-ingest. It's a lethal compounded drug, a lethal drug that they then might self-ingest that would cause their death, in just a few minutes, and that would be their way to avoid the current or imminent suffering that they fear.
Thank you for that. It's helpful to kind of recontextualize it. Despite being immersed in this work, it's helpful to kind of recalibrate of like what's really the essence here. And you mentioned a dependency for patients who might be dependent upon dialysis treatments or might be waiting for a kidney transplant or a feeding tube or a ventilator. So a dependency on a physical mechanism for life extending treatment. Is that accurate?
Yep.
So in the context of patients who qualify for medical aid in dying, their illness is creating a terminal condition where their death is foreseeable in the next 6 months based upon the state law where MAID is legal in the United States. And go ahead.
I was just going to say that I would just change one word, and maybe this is me being too much of a lawyer. It's not just that it's foreseeable. It's likely, right? So it's more probable than not. So it's great. In other words, the doctor needs to be able to say, both doctor, because it's normally two, they need to be able to say probably, right? More likely than not, this patient will be dead in the next 6 months. So anyway, sorry, it's probably way too much of a quibble.
No, absolutely. No, thank you. I'm wondering, folks often who object to medical aid in dying often have a kind of visceral response by saying, it ought not be in the patient's control of when they die. And yet you just made a brilliant illustration of patients have been able to control in many ways the timing and circumstances of when they die based upon turning off a physical machine.
It's worth remembering just how big of a number that is. I mean, we're talking more than 1 million patients. I mean, so many patients die in we can even zero it down, right? Just forget all of healthcare settings. In a hospital setting, right? A substantial percentage of all patients that die in a year die in a hospital setting. Very few people that die in a hospital setting just die, right? Despite the deployment of, all life-saving, life-prolonging technology. So somebody made a deliberate and intentional decision to stop keeping the patient alive. So it's a very big number. And maybe I would further accentuate this point to think if you have 1 million people that are turning stuff off every year, only about 2,000 people use medical aid in dying. So it's incredibly small number of people that die through MAID versus the number of people that die as a result of one of these deliberate decisions, right? New York and every other state is encouraging people to do advanced care planning, encouraging at least the seriously ill to complete a POLST or a MOLST. And overwhelmingly, POLST and MOLST is they don't need to be completed this way, but generally they are completed in a way that you are going to decline CPR, that you're going to decline other therapies to keep you alive because you say, well, I'm dying. I'm not going to get back to baseline. And so anyway, people are using all of these tools themselves, their healthcare agent, their advanced directive, their POLST, basically to hasten their death. And it happens every day, and it's happened for decades and decades and decades in every single state in the country.
I really find it interesting that the idea of hastening death is acceptable large scale now. It's been several decades, but it does seem like it's on a large scale, and correct me if I'm wrong, more acceptable now than it was in the 1970s. Versus for someone looking to hasten their death with medical aid in dying, that's, perhaps still too new, although the movement's been going for 30 plus years.
Yes. So, yeah. And I think so you think, oh, we've accepted hastening death for decades. And maybe you're right that we accepted even more in 2024 than we did in 1984. So this is just one more means of hastening death. So why is it so controversial? Probably the biggest response to that would be what people call the active passive distinction, which is all of those things is just stopping. In other words, death was happening to the patient and we stopped it with some kind of artificial device. And so we're just stopping the device and then allowing death to continue. Here we are affirmatively introducing a lethal agent. And so I think that's I think is this active passive distinction might be the biggest difference. Is it sometimes it goes to the intent, meaning we actually want to cause the patient's death, but in the other situations we just want to relieve the patient of the burden of that technology Or sometimes it's framed in terms of causation, which is we didn't cause the patient's death. Their underlying illness caused them to be unable to breathe. We just didn't save them from that. But again, with MAID, we are giving them a lethal substance that is going to cause their death. So this is intent and this is causation. And maybe in the regular ICU situation, we don't have intent and we don't have causation. I don't believe that. I'm just saying that I think that's the argument.
You know, it's interesting. In Andi Timoner's film, Last Flight Home, you know, she visually depicts her father, Eli, who's bedridden with, you know, painful bed sores on his back, and he opts for medical aid in dying in California. And as an audience member viewing that film, and I know others have too, had a visible and visceral reaction to Eli's suffering. And it was palpable, you know, on the film that Eli was on the verge of dying and he was ready to go, and it was the right thing to do. Is it feasible to say, or reasonable to say rather, that for the terminal criteria of 6 months or less, that folks might think if they have some life to live, even if it's 2-4 months, that for a patient who meets the criteria that they're opting out of life that they otherwise would have lived, even if they were in a period of physical unrest, discomfort, and the like?
I think, right, and this I think is exactly where the argument against MAID breaks down, because on first of all, just stick to pure time, right? Just because you can qualify for MAID when you have a 6-month prognosis, nobody's taking the medication at the 6-month prognosis. In fact, many people never take the medication, so they're only taking it. They're only getting the prescription to have just in case their suffering gets to the point that they're afraid of. 30 to 40% that suffering never gets to that point, and they never take the medication because hospice and palliative care was able to completely address the suffering that they were worried about. Even the others who do ultimately take the medication take it only when things progress. And typically that's going to be very close in time to the point at which they would have died anyway. So we're not talking about the last 6 months of life. We're talking about the last 6 days, 6 weeks of life between the time that they take the MAID and the time that they would have died anyway. So it's a very small amount of life anyway. And then the even more important point to me, though, is whatever amount that is, that's life that they found to be intolerable, that they didn't want to live in that situation. They didn't want to have to live in that situation. They didn't want to have their family to have to live with them in that situation. Yeah, so I think again, right, that these real stories like she captured in the film are powerful reminders that how could Sarah, how could you or I say, no, Timoners, you know, that's wrong. You don't get to do that. That's a stupid decision. I mean, I think I don't see how we could, or how the state of California could say, no, that's a stupid decision. We're not going to let you do that.
Well, I know this debate has been going on for a long time, and I'm sure it'll keep going on for a long time as well. And so help us kind of reorient to what's on the horizon now for expanding and implementing medical aid in dying, and in the United States in particular. I know there's a lot happening out in the world, but just focusing on the US, what can we expect to be changes from now to the next 12, 18 months?
Yeah. So just to give everybody a quick baseline, right? MAID is available in 11 states or 10 states in Washington, D.C. And about 70 million people live in those places, right? So a lot of people have access to MAID. Secondly, and I know we're going to get a little bit into this later, people from the other states, the non-MAID states, can go to the MAID states. So it's not just the people in those 11 states. People from the other 45 can go to one of the 11. But let me just quickly tell you also what's happening right now, and then we can talk about what's coming up next. So what's already been in progress for the last, maybe let's just say 3 years, has been an expansion of access, right? So originally, everybody was focused in a very binary way. Like, are we going to allow MAID? Are we not going to allow MAID? It's like yes or no, off or on. But now, a lot of the data showed a lot of people, even in a MAID state, even in Oregon, the original state, have trouble accessing MAID. And so Oregon, and in fact, most of the current MAID states have gone back and amended their MAID statutes to make them more accessible. So they already permitted MAID, now they permit it on terms and conditions that make it more accessible. So that originally it was a 15-day waiting period, right? So you have to ask on day 1, ask again on day 16. Well, since people sort of wait until rather late in their terminal illness, many people couldn't wait the 15 days, right? In other words, they didn't ask until things got bad. So they're going down fast. Okay, so they shorten the waiting periods or make them waivable, right? So your doctor say, Sarah can't wait 15 days. Okay, she's excused from having the 15 days. Many states, rural states like New Mexico, big parts of New Mexico don't have physicians, right? They have APRNs or physician assistants. So many states have now permitted not just physicians, but other types of licensed healthcare professionals to provide MAID because they're more available, especially in rural areas. Same thing for the mental health assessment to determine if you have capacity. Used to be just a psychologist or psychiatrist. Now we let licensed clinical social workers and some other types of licensees do that. And then we're going to get to this, but I know Vermont and Oregon have dropped the residency period, and that's being considered in New Jersey right now. And then finally, the other thing that's been happening is transparency. So all the states allow religiously affiliated clinicians or religiously affiliated facilities to opt out. Right? If nobody needs to participate in MAID if they don't want to, whether you're a patient, a doctor, or hospital, or hospice. Well, a lot of people opt out because especially in the upper Pacific Northwest, 30, 40 or more percent of all healthcare is Catholic affiliated. Well, what Colorado, California, and Washington have done have at least pushed some level of transparency, so people can find out who's in and who's out, and then they can make a more informed choice about where to seek their healthcare. So that's the stuff those are the changes that have been happening. More states, if you look at the bills, we had 50 bills in 2024. Many of those bills had 1, 2, 3, or 4 of the changes that I just discussed in the bill. So the new states are likely to continue replicating those changes. So that's what's in what's coming up next to your question. I think, well, first thing is those are going to continue to expand and spread, the ones I just discussed. The second thing is there was a bill, and you mentioned it briefly, SB 1196 in California. It proposed a lot of stuff, and I think some of it is actually feasible, and some of it might be in the more distant future. The stuff that I think is lower hanging fruit, and this is just me, so I might not be politically tuned in enough to know whether it's really politically viable, but I think IV administration. So today, that powdered medication, DDMA-PH, needs to be mixed. Typically, people mix it with 2 ounces of apple juice and they drink it. If you can't drink it, you can have it, you can put it in a plunger and you could have it administered rectally, or if you have a feeding tube, it can be put in through your feeding tube. Nobody does IV administration, intravenous administration, but the evidence shows that would be safer and it would be more effective. And that's what every other country does. So I think that's not as big a deal because we're not changing who's eligible for MAID, and all we're changing is the way in which the drugs get into your body. And in SB 1196, even though it's IV administration, it's self-administered IV administration. The patient is still pushing the button to make those drugs go in her body. So you're not taking away the self-administration requirement that a lot of people care about.
So was California SB 1196, was that, it sounds like the IV administration was not the only criteria that they were aiming to expand. And I know Senator Catherine Blakespear courageously put her name behind this expansive proposal. Why was that proposal considered so drastically different? And why do you think it didn't go through? Although I agree that it would be wonderful to have a safe and reliable and effective means to administer than to have, a cocktail to drink or a syringe to push.
Yeah. Well, I think that well, okay, two levels here. The first level is the super practical level, which is everybody came out in opposition to it. So even Compassionate Choices, which is the primary advocacy organization that lobbies for, promotes, and does education on MAID. I mean, frankly, the fact that we have all the MAID legislation that we have is largely thanks to Compassionate Choices. So your primary defender, advocate, and champion of medical aid in dying says, don't pass this bill. So, okay, so that's the super practical answer. But then the bigger question then is, well, why did they do that, right? Why wouldn't they want more MAID? Well, I think what SB 1196 did was, you're correct. It wasn't just the IV administration. It was a lot of stuff all at once. So perhaps most controversially, they proposed eliminating the traditional 6-month requirement. So as we just discussed, right, the patient needs to have a serious and irreversible illness likely to cause their death in the next 6 months. That in SB 1196 would eliminate that and follow the Canadian definition of it. It's enough that the patient has a grievous and irremediable medical condition. And there's no temporal requirement. So their death doesn't need to be within 6 months. It doesn't even need to be reasonably foreseeable. So in fact, the bills explicitly permitted dementia patients to have access to MAID. So if you have capacity today and you have dementia, like let's say you're stage 2 Alzheimer's, you're not going to die from Alzheimer's probably for 5 or 6 years or more. But now under SB 1196, you could have MAID today to avoid having to get to the parts of Alzheimer's that you're worried about. So it's a big change in that timeline, right? Before we're saying we're only letting people who are already about to die hasten their death. Now we're letting people, they weren't about to die. They weren't even close to dying. We're going to let them have MAID too. So I think that was the more controversial part.
And just to clarify, they would be in, you said stage 2 of Alzheimer's dementia, but they would need to self-administer the MAID drugs rather in that stage and not wait for it to progress further.
Well, okay, right. So this is where it gets super tricky, right? Where, okay, because the way MAID works is sort of this outpatient procedure where we just give you the drugs. So you show up and you get them. Well, if you don't take them soon and you have a progressive dementia, you're going to lose capacity soon. And therefore, if you don't take them when you have capacity, you should never take them, right? Because then you're not taking them with capacity, which means, so you're right. Nobody is authorizing or proposing what you might say euthanasia by advance directive, right? So that's what they have in the Netherlands. That's what they have in Quebec, which is to say the person in stage 2 Alzheimer's writes it down in an advance directive. And they say, when I get to stage 7, can't recognize my family, can't go to the bathroom, don't know who I am, so forth. Then I want the doctor to show up, put the needle in my arm and euthanize me. That's okay. I mean, that happens in the Netherlands and the law supports that. Nobody's proposing that. So on your 12 to 8, that's nowhere, that is completely nowhere in the 12 to 18 months. That's probably not even 12 to 18 years for the US, because that crosses too many lines all at the same time. First of all, you're moving from assisted, medical aid in dying to straight up euthanasia because the clinician is doing it. Secondly, it's not contemporaneous consent. It's consent to an act that was given years before the act. So it's too much. I mean, that's way off. They not even the SB 1196 guys were going that far. So yes, you're right. It has to be. It's still contemporaneous and it's still self-administered. Yes, and with capacity.
It's such an important distinction because that bill was kind of revolutionary and kind of bold in its presentation, and let's see what happens in the next couple of years if it's reintroduced next year.
Well, I think I think what's interesting is there's the bigger question, not than just that specific bill, which is for political purposes, we have very conservative MAID laws, right? So compared to any other country on earth, right? Spain, the Netherlands, Belgium, Luxembourg, New Zealand. I mean, so
Portugal just came out a couple
right,
years ago.
Right, Portugal, Colombia, right? So the most conservative, narrow, right? In other words, who's eligible, how's it done, but the approach has been, look, let's stick with that model, right? The 6-month eligibility requirement, self-administration, oral through the gastrointestinal tract. That nobody's messing with any of that, because the approach has been it's better to move from 11 states with the narrow model to 12, 13, 14, 15 states with the narrow model than to risk it all and to start shooting for the stars, or to shoot too high and go for the SB 1196 model. So that's been the approach for ever since 1994, 30 years this year since Oregon passed its ballot initiative. So I think SB 1196 is, I think, a manifestation or a symptom of some people's frustration that, look, isn't it time to expand the model at least a little bit, because MAID works. We've shown that it's politically feasible. We've shown it's clinically feasible. So can't we start considering changing the parameters of who's eligible for it? So I expect that we'll see other SB 1196s, not only in California, but in other states, because people are eager because there are people who are suffering, and MAID would be a way for them to avoid that suffering, but they're not eligible for it. What will probably happen, by the way, is it will happen in the way that following what I just said a few minutes ago, which is you take the current MAID states, they pass the MAID bill in year 1. In year 3 or year 4, you come back and you amend it, right? So you come back, you take out the residency requirement. You come back, you allow APRNs. You come back, you change the waiting period. So in that whatever you want to call it, the amendment stage, I think some of the current MAID states, basically like California is doing, will come back and do one or more, or at least, try to do one or more of the things that SB 1196 was doing.
And we saw that with not only Colorado expanding its amendments recently, but also notably in the last couple of years with Oregon and Vermont, which passed MAID at different times, Oregon in 97 and Vermont 10 years ago or so. And they took a step and said, okay, we'll remove a residency requirement. And now new states are offering, at least a couple I saw were offering without the residency requirement.
Oh, absolutely. When you look at the new states, and what we're calling new states, which are states that had bills, which was a lot of states, many like Minnesota, where I am right now, no residency requirement. We passed 4 House committees this year. No residency requirement. Interestingly, the Colorado bill you just mentioned did pass, which reduced the waiting period and allows APRNs to prescribe. But the residency requirement needed to be taken out because that was the thing that was blocking the vote. So in other words, it's, people make this decision to say, we're trying to do 3 things here: reduce the waiting period, expand the number of licensed clinicians, and drop the residency requirement. We're not going to get the votes if we try to do all 3, so we'll drop this one and focus on the other 2. So maybe with the SB 1196, like I said, they were trying to do a number of different things, and I think they needed to there's some kind of boating term, or off-lift something out of the boat so the rest of the boat can keep afloat, right, and sail through the legislature.
Maybe in a strategic calculation that, would guarantee their success.
Yeah. Or sometimes, it's interesting in Michigan, what they do is they have a bunch of bills about the same, so they carve it up. I mean, we probably don't want to get into the weeds too much on legislation, but like if they're doing a bill, like let's say it's a bill about Pulse, right? Oh, this is the Pulse bill. Then there's a completely separate bill with a separate bill number saying that APRNs can sign the Pulse. Then there's a separate bill that says PAs can sign the Pulse. Then there's a separate bill that says you have immunity for following a Pulse. I think the idea is like, hey, if somebody has a problem with one of these, at least the rest of them will still pass. So
well, if you take the stick out of the straw house, at least it won't fall down.
Right. Good. That's a good metaphor. But those are the things I think. There are things, that I think, like the self-administration requirement. I don't believe that's super ethically important. I think we can confirm people's consent, their autonomy, their voluntariness by talking to them. I mean, we don't like with all other medical stuff, we don't say, oh, Sarah, are you really sure you want to do this surgery? Here's the scalpel. You make the first cut, right? We don't make the patient literally participate in their healthcare in any other healthcare procedure in order to have confidence that it's a truly autonomous and voluntary decision. But here, the opponents are like, oh no, the only possible way we can know that this was a voluntary decision on Sarah's part is if she drinks it herself. I'm like, no, I don't think that's right. That said, I don't see I don't see us moving to Canada and having clinician administration, not because it's not ethically justifiable, not because it's not a good idea, but just because politically it freaks people out and they're not going to vote for it.
Mm-hmm. That's a valid reason to strategize other options, for sure. So you touched upon Oregon, Vermont removing their residency requirement, and other states potentially being established with that criteria already removed. And thinking through telehealth is growing in its capacity, and I know it's used by MAID providers in different kind of rural areas to evaluate patients. Can you walk us through, is telehealth something that's on the horizon as a potential factor in playing towards helping patients access MAID? Is that something
Oh, it's a big factor. So a lot of patients who have been getting MAID and are getting MAID right now are having 1, 2, or 3 of their assessments done through telehealth. I mean, that's, yeah. The easy examples are Hawaii, because sometimes the patient is on a different island, right? So the clinic, now you have to wait, right? It really would slow stuff down if you have to wait for the doctor to get a plane to come over to your island. Same thing in New Mexico. There's big desert open areas of New Mexico. So it's been really important already. I think a large percentage of patients, there's 1 or more of their assessments is done through telehealth. I wouldn't link it to the other thing you mentioned, though, which is the residency requirement, because when I'm talking about the patients getting telehealth, it's New Mexico patients getting telehealth with New Mexico clinicians, or it's Hawaii patients with Hawaii clinicians. There's no telehealth crossover from state to state, because just because it's telehealth, if I'm a doctor and I'm here in Minnesota and I'm talking to you in Manhattan, I'm not licensed to practice in Manhattan, right? So first of all, that means I'm engaged in the practice of medicine in New York. So first of all, I'm engaged in the unlicensed practice of medicine, or practicing medicine without a license, which is a crime. But also it means that under the MAID laws, you're not eligible, right? Because you're not. So I don't think that's happening. I think if you're a New York patient, you can go to Vermont and get MAID. Yes. But I think I'm very, very sure that every Vermont clinician is going to say, there's no telehealth. I mean, you got to come. Now, maybe once you get into Vermont and you can prove that, I don't know, you show you say, look behind me, here's this sign or something. Maybe, you know what I mean? The telehealth is within Vermont, but I don't think they're going to cross the state lines, because otherwise they're engaged in providing MAID in New York. And I don't think New York would be happy about the fact that somebody's providing MAID in the state of New York.
Right. It's an interesting kind of distinction to think through, kind of the practicalities of, okay, telehealth could be really helpful, but there are important practical restrictions that just because Vermont and Oregon seemingly have free and open doors doesn't mean it's necessarily something that you could implement. I think it's easy to make a lot of assumptions about the states where there's no residency requirement than there are for states that do have the residency requirement.
Yeah, I think there's two things just to remember. I mean, maybe this might be helpful for people to think about, is a lot of attention and focus and emphasis is put on the fact that there are some states with residency requirements and some states without residency requirements. The residency requirements in every single MAID state are so weak and low that there isn't actually very much difference between a state with a residency requirement and a state without a residency requirement. So people, if you're a terminally ill New York patient, you can go to New Jersey and you can become a state resident today. I mean, it's not hard, or Oregon, right? I mean, one of the traditional indicia specifically identified in the statute is, do you own or lease property in Oregon? Well, we can go on Craigslist right on our call right now, and find something, Venmo them some money, and they'll send us a lease. And now we have property in Oregon, which for the purposes of the MAID statute means that we are Oregon residents, so that we can do it in the next 5 minutes. So it's, so I don't know that, residency requirement, no residency requirement. Yes, it's easier. Now we don't have to go through that little Craigslist real estate rental thing. But your other point is super important, which is it also doesn't mean that all bets are off, because in the other states, so New York and Minnesota, it is a crime. It's not just that it's not affirmatively authorized or it's not offered and it's not available. It's a crime. And so if the Oregon doctor helped you do something in New York in terms of giving you a prescription or even doing the assessment, that for the purposes of MAID means that they've committed a crime in New York, or committed a crime in Minnesota. So you're still going to have to go. The people in the non-MAID states are going to have to get in a car or get on a plane and go to the MAID state. Telehealth isn't really, it's a great option for the current people in those states, not a great option for the patients in non-MAID states.
I'm wondering, how might we build best or better practices and standards of care among and between states with a lot of flow, and perhaps migration patterns in those last, couple months of life?
That's a super great question. And maybe I'll pick it up where you left off there with Patient Choices Vermont. So there are these organizations, I guess they're typically 501c3 driven largely by donations. They're critical in most states. So, and let me just back it up for a second. Even in Vermont, even in Oregon, even in Washington, people are like, I heard about medical end-of-dying, how do I get it, right? So the organizations like End-of-Life Washington, End-of-Life Choices Oregon, and there's similar organizations in New Mexico, similar organizations in New Jersey, and then you mentioned the one in Vermont. These organizations are pivotal even for the patients that are already in those states, because, for example, a lot of people in some of those states are in getting their health care from a religiously affiliated organization which doesn't provide MAID. So they're like, well, my doctor's not going to do it. How do I find a doctor that will, right? No clue, right? People have no clue. These organizations do a great amount of coordination work. And I think to your question about the interstate stuff, I think they're also picking up a lot of the related work of helping facilitate for the non-residents as well. Because if you're in North Carolina and you think, I'm going to go to Vermont, I would call patient choices. I mean, because otherwise you're going to have to call, what are you going to do? Call doctor by doctor. So I think these organizations are pivotal. And it's weird because I don't know that we should rely this heavily upon charities to provide to facilitate the coordination of healthcare. But that is, right now, we are I think, very dependent upon them to do a lot of coordination work. And thank goodness they're there.
Oh, absolutely. And so is it fair to say, or maybe to project, that improving better practices among interstate connectivity in this sense would be to bolster support for these state-based end-of-life organizations that are doing this essential coordination work?
Yeah, I mean, yeah, I think that would be one. Yeah, I mean, that's a very interesting question, right? I guess I wonder, even from their own fundraising perspective, they think, like, originally the only people that we served were, the End-of-Life Choices Oregon served were Oregonians, right? But now that we're technically serving the entire nation, because anybody can fly to Portland now, that maybe some of those people should also help support us and they should write us a check, because we're serving the entire country, so the entire country should serve us. I think that's right. I mean, I guess it's unfortunate that the only two states that remove the residency requirement are rather small states. I mean, if California removed its residency requirement, there's obviously major cities, there's a lot of MAID providers, because it's such a humongous state, right? That would be a game, or New Jersey, right? So that would be a game changer. But at least so far, the only two states are these relatively small states, and they're not easy to get. At least Vermont's not super easy to get to. So, but I think that is where we're going to have to be for right now. I would mention one other one. So there's each state has one of these state organizations that does a lot of this coordination work, helping match patients and doctors. There's also a national organization, ACA MAID, so the American Clinicians Academy on Medical Aid in Dying, also has a patient referral service. So if you're a patient anywhere in the entire United States, Kentucky, Texas, or whatever, and then you need to find a clinician in Oregon, or even if you're a patient in Oregon and you need to find a physician in Oregon, ACA MAID has a very effective referral service. So that's in addition to each of the state organizations, there's also this national organization.
It's such a helpful reminder, because I think if you're someone coming to this topic completely fresh, I can imagine that all of this information might be a slightly bit overwhelming, and it's so helpful to reiterate the differentiation of the state-based role versus, ACMAID's incredible role nationwide. Well, so many important things on the horizon, and I look forward to future conversations where we get to revisit this, and I get to say hi again, Thad. What do you think now, in 5-10 years? So I'm really grateful for your time and your expertise. And are there any last thoughts you want to share before we sign off today?
No, but I hope people who are listening in other like New York and other MAID states contact their organizations in I guess it's going to be January when the new legislative session starts. I mean, if after listening to Sarah and me and the other people in this series, you think that this is an important end of life option, then contact your advocacy organization and ask what you can do in terms of writing a letter to your senator or other efforts like that, because I think that kind of thing really helps. It really matters, because often these votes are very, very close, 49-51 in splits like that. So one more vote, can really make a difference.
Well, so many great insights as always, Thad, and I'm just so grateful for your time and your presence today, and thank you for being here and for illuminating our last Hello Symposium for not only the U.S. but the rest of the world. So I'm very appreciative of what you've shared today, and I look forward to speaking with you next time.
Me too. Thank you, Sarah.